me while this goes through the process.
Hi, my name's Chloe Medalia and I'll be talking to you on the pharmacological and non-pharmacological interventions for rheumatoid arthritis, mechanisms of action, and their effect on client health outcomes. Rheumatoid arthritis is an autoimmune disease, which means that the body attacks itself. Rheumatoid arthritis causes synovitis, which is inflammation of the synovium, in multiple joints, resulting in pain and stiffness, fatigue, reduced function, disability, emotional and social burden, and pharmacological interventions aimed to reduce inflammation. RA is a progressive disorder, with the clinical course described as having periods where the disease is active, punctuated by periods of remission. RA is an inflammatory disease resulting in destruction of cartilage and underlying bone. Nociceptors from the joint capsule and synovium are triggered by movement of the affected joint. As you can see here in this picture of a bone, a difference between osteoarthritis and rutaid arthritis. So osteoarthritis and rheumatoid arthritis also both have cartilage destruction. There is much greater inflammation of the joint capsule and the synovial membrane in rheumatoid arthritis. The prevalence of Australians with rheumatoid arthritis is 2%, and this has remained unchanged for the past 10 years despite the advances in treatment and management. Rheumatoid arthritis results from an increase in an autoantibody called the rheumatoid factor, and it's found in 80% of patients with RA. They have a positive serology of this rheumatoid factor, which is tested as the human leukocyte antigen, HLA. As a result of an interpreted virus, lymphocytes stimulate macrophages to produce inflammatory mediators such as the tumor necrosis factor, causing degradation of the synovial fluid. In this chart here, you can see the different ways that physicians will test to see if patients have rheumatoid arthritis or not. The first test is the number of joints, whether they're large joints or small joints. They'll do a blood test for serology and also assess the length of time that patients have had symptoms to test whether treatment is necessary. There is a range of pharmacological and non-pharmacological interventions for rheumatoid arthritis, with the goal being to stop inflammation and put it into remission, relieve symptoms, prevent joint damage, improve physical function and overall well-being, and reduce long-term complications such as disability. During this presentation, I will outline the pharmacological and non-pharmacological interventions for rheumatoid arthritis, mechanisms for action, and their effect on client health outcomes. At the end of this presentation, I hope you will have a good understanding of recent evidence-based practice options for RA patients, how to best assist patients with pain management, and how to provide suitable therapy for RA patients to maximize quality of life. So first line of call is the non-steroid anti-inflammatory drugs, also known as NSAIDs. These are analgesic, anapretic, and anti-inflammatory compounds you find in your chemist, such as aspirin, ibuprofen, naproxen, and Selexicop. They work by blocking the production of prostaglandins, which is similar to a hormone. It plays a key role in generating the inflammatory response. NSAIDs inhibit prostaglandins precursor, simply called COX-1 or COX-2. They are both selective and non-selective COX inhibitors. Selexicop inhibits COX-2 and naproxen inhibits COX-1 and COX-2. So COX-1 are the good guys. They're involved with biosynthesis of prostaglandins serving homeostasis, and COX-2 increases during inflammation. Inhibition of COX-2 blocks prostaglandin production at the inflammation sites. Inhibition of COX-1 can cause bleeding and gastrointestinal ulcerations. NSAIDs can have adverse effects on renal, hepatic, and cardiovascular systems due to the blocking of prostaglandins. The incidence of severity of adverse effects from NSAIDs increases with age. NSAIDs should be used at the lowest effective dose for the shortest possible time. This chart here shows the effectiveness of celecoxib compared to naproxen and a placebo, testing patients' tender joints, swollen joints, their global assessment, the improvements of the global assessment. So the greatest results were for celecoxib 200 milligrams. So they had the greatest reductions in tender and painful joints, swollen joints, and the best results for the patient's global scale. The next group is disease-modifying anti-inflammatory drugs, also known as DMARDs. These can reduce the rate of radiologically detected joint damage and reverse disability. Most commonly used DMARD is methotrexate. It inhibits purine biosynthesis, which is a derivative of folic acid. Folic acid is an essential base synthesis in DNA and RNA. Therefore, MTX works as an immunosuppressant and inhibits synthesis of DNA and RNA. Here on this graph, you can see a number of tests testing the SWJC down the bottom there, swollen joint count, joint tenderness count, tested from 5 journal articles of parallel and crossover design, number of weeks, different amounts of dose, and we can see that methotrexate compared to the placebo had a greater reduction in swollen joint count and joint tenderness count than the placebo. Methotrexate is the most commonly used DMARD in initial treatment because of increasing evidence that it is effective with minimal side effects. Because of the evidence base, MTX is used for early aggressive intervention. The most common side effects include nausea, headaches, malaise, and gastrointestinal distress. Another effective DMARD is leflunomide. Leflunomide and MTX are synergistic in combination and have been proven to be effective for the treatment of patients with active RA who are resistant to treatment of MTX alone. Leflunomide prohibits pyrimidine biosynthesis and lymphocyte proliferation. It stabilizes the overactive cells in the immune system that cause inflammation of the joints. Leflunomide is an immunosuppressant as it prevents cells from re-entering the DNA replication phase of the cell cycle. A meta-analysis of pooled data from individual patients enrolled in Phase 3 randomized control trials comparing the clinical efficacy of leflunomide with placebo and comparative drugs reviewed the clinical course of 1,817 individuals with rheumatoid arthritis from 6 peer-reviewed journals. Leflunomide-treated patients showed a significant improvement in disability with mean health assessment questionnaires scores decreasing at 12 months by 0.37 compared with an increase in placebo health assessment questionnaire scores of 0.06 at 12 months. In a prospective double-blind trial of 39 rheumatoid arthritis patients, leflunomide and MTX were compared over 4 months. Both treatments results provided comparative reductions in synovial inflammation. As leflunomide is more expensive, doctors usually prescribe MTX first. Biologic treatments involve targeting specific inflammatory pathways. These targeted therapies include TNF inhibitors and B-cell antigens. Biologic agents specifically block the activity of single cytokines produced predominantly by macrophages. TNF inhibitors block cytokines, which are signaling molecules which regulate immunity and inflammation. These cytokines are released by macrophages in response to inflammation stimuli. Drugs that block TNF have been found to decrease joint inflammation and slow radiographic progression. However, these improvements have only occurred in 40% of patients, achieving 50% improvement. Anti-TNF therapy has been found to increase the rate of serious skin and soft tissue injuries. In this chart here, we're measuring CA2, which is a TNF inhibitor. As you can see, the morning stiffness, the pain scores, and the swollen joint counts from initial screening to week 6 have decreased, and the grip strength on the left and the right hand both have increased. Next is B-cell antigen inhibitors deplete B cells through cell-mediated cytotoxicity and promotion of apoptosis. B cells contribute to the initiation and maintenance of inflammation in rheumatoid arthritis by producing pro-inflammatory cytokines and autoantibodies, and by acting on the antigen presentation by T cells. B-cell antigen inhibitors are associated with rare cases of progressive multifocal leukoencephalopathy, PML. PML is a rare demyelinating disease of the central nervous system, occurring in patients severely immunocompromised. In this chart here, we can see various rituximab randomized controlled trials in patients with rheumatoid arthritis. We're using different dosing regimes of rituximab. Were tested in combination with MTX. Shown to achieve similar efficacy and to provide superior clinical response than MTX alone. So as you can see on the right hand side under remarks, most patients, whether there's a no significant response between MTX and the TNF, coming down to MES, anti-TNF failure, patients with very high disease activity at baseline, no differences. Non-pharmacological interventions. Despite the progress made in pharmacological therapy of rheumatoid arthritis, many patients continue to have active disease with high risk of later disabilities. The most recent review of clinical practice guidelines for non-pharmacological interventions using the appraisal of guidelines for research and evaluation tool found the best recommendations were patient education, self-management, aerobic, dynamic, and stretching exercises. There is a small amount of support for balneotherapy and herbal remedies. However, for this presentation, I will focus on the treatments with the strongest evidence towards health-related outcomes. Patient education, self-management. Self-regulation has been found to reduce psychological distress and increase self-efficacy in RA patients with subclinical levels of depression and anxiety. Improvements in perceived ability to control RA and self-efficacy to manage symptoms are believed to be the dependent cause for the results. Techniques that are involved with self-regulation interventions involve goal setting, self-monitoring, and receiving feedback. These have each been linked to improvements in self-efficacy, which in turn improved psychological variables in RA patients. This graph here shows that over a matter of time between intervention and a follow-up procedure, there was amount of reduction in self-efficacy for patients, maybe taking a little bit longer for some patients to adapt and to provide themselves with those small things to achieve and achieving them and feeling better from them. Coping effects increased, psychological status improved, disability decreased, and pain decreased. So from this study, some interesting results. Aerobic exercise and strength have been found to improve without negative effects on pain and disease activity in RA patients. The American Physical Activity Guidelines of 2007 provide an acronym for health improvements in patients with arthritis. SMART. Slow progression in intensity, modify the activity if necessary, a physical activity must be joint friendly, recognize the best places to exercise, and talk to a specialist. Physical activity has been found to relieve pain, maintain the function of affected joints, and improve general well-being of patients with RA. The main cause of reduced life expectancy in RA patients is cardiovascular disease. Meta-analysis of exercise-based cardiac rehabilitation estimate a reduction in mortality of around 20 to 30%. Physical activity programs improve fitness, muscle mass, reduce adiposity, improve strength, and physical function. Approximately 2/3 of RA patients suffer from cachexia, a significant muscle wasting. Cachexia is able to be reversed by high-intensity resistance exercise in RA patients. This graph here is where the highlighted area is. It's showing the potentially if you turn those reversed arrows up to the other way. This is how I interpret this graph, that when you are exercising, you could increase your power, you could increase your strength, you could increase your muscle mass. In tendons could be strength, but at the moment with cardiovascular disease and reduced function and inflammation and pain and fatigue, it's all just a negative cycle. So with doing some exercise, you put exercise in there instead of cardiovascular disease, and you'd be able to change all of these comments around to a positive. These are the ACSM exercise guidelines for clients with rheumatoid arthritis. So able to be doing cardiovascular activities, strength training exercises, stretching exercises. There's not a heap of evidence at the moment on balance exercises, and so the parameters are unclear. But we have here the number of days per week, time per session, heart rate measurements, and how to periodize the program as well. In conclusion, NSAIDs are the first line of call for pain management. If pain worsens, DMARDs are the second line of call. And pain persists, biological treatments are the third line of call. Maintaining fitness, strength, and self-efficacy through self-management are essential to reduce the chances of comorbidities such as CVD and cachexia. Practical implications in integrated management plan will assist RA patients, minimize the use of pharmacological interventions, participate in cardio and strength work, and get your patients some into the self-management program. And thank you for listening today.